Slides ready to go.
I see you. You're in the room.
Okay. Let's hang up, I guess, on the phone. Are you able
Hi,
to hear
everyone.
me?
Hello, Dr. Kotlar. Can you hear me?
Yes, can you hear me? Can you hear me?
Dr. Kotlar?
No audio? No
Oh,
audio?
you have audio. It's me. It's me.
Hold on. Let's just make sure you hear me okay?
I do hear you okay.
Okay, good.
Y'all, please forgive us. We're just running a minute behind. We had a little connection issue. Okay, Dr. Kotlar, if you will click the button to the right of your microphone to turn screen share on. I hope everybody's having an amazing Tuesday. We are so excited to have my dear friend, Dr. Marty Kotlar, here to talk about how to appeal denials and scrub EOBs. And I really can't think of anybody better to address this topic because he breaks it down to the nitty gritty and makes it really easy to give you kind of like a checklist for making sure that you're not letting money slip through your fingers by not following up on these things. And in case you have not heard of Dr. Marty Kotlar, and then I ask, where have you been? Because Dr. Marty Kotlar has been a great mentor to me since my very early days, starting in chiropractic at ChiroHealthUSA almost 11 years ago. He is the president of Target Coding, has owned and operated a successful chiropractic practice for 12 years and a multi-specialty practice for 4 years. He began his consulting career with a special emphasis on CPT coding, billing, reimbursement, documentation, and compliance for chiropractic and multi-specialty facilities. If you are a multi-specialty facility, he is your go-to guy to get those questions answered. Over the last decade plus, Dr. Kotlar has provided valuable nationwide educational seminars and consulting to over 3,500 healthcare providers and their staff members. And on a fun note, I will add, Dr. Kotlar is the only consultant that I know that pre-COVID hosts an educational seminar on a cruise ship. It is a must-attend event, and you can learn more about Dr. Kotlar and his amazing company, his awesome team at www.targetcoding.com. Dr. Kotlar, thank you so much for being here today.
Well, Christy, thank you for having me. I want to thank everyone over at Chiro Health for inviting me to do these. I really enjoy doing them. I hope everybody else enjoys them also.
Oh, absolutely. That's why we keep bringing you back.
Excellent. So some connection problems occurred, a couple of, technical difficulties. So I hope everybody could hear me and see my screen. And Christy, should I just get started?
Absolutely. Take it away.
Okay. So yes, Christy gave me a very nice introduction. I guess I consider myself kind of unique because most chiropractors are not certified coders and most certified coders are not chiropractors. So you'll see during this webinar how I combine both specialties to make sure you're doing things right, you're complying with laws and rules, and you're getting paid what you deserve. So yeah, today's topic is how to appeal denials and scrub EOBs. EOB stands for Explanation of Benefits. The most common denial that we see here at Target Coding from insurance companies is denied. Why? The services were not medically necessary. So for some offices, they just give up at this point, which we don't think is a good idea. The insurance company is hoping you just go, oh, okay. So, and maybe it's okay if it's an insurance company where you're out of network and you have no contractual obligation. You could have the patient pay you cash, but if you're in network and you deliver a service and it comes back not medically necessary, I don't think it's a good idea just to say, all right, just write it off, because you can't collect it from the patient. You have to find out why. That's the key. Why not? Why isn't it medically necessary? Why aren't you going to pay? So here are some of the most common reasons. You'll see something like, oh, the service was bundled, the patient has reached maximum therapeutic benefit. Sometimes you go, wait a second, how could it not be medically necessary? This is the first claim that I'm submitting. Maybe it went towards the deductible, a duplicate submission. If you submit your notes, maybe it comes back denied because goals have not been established, not enough improvement is being shown, or the more common reasons during a typical claim submission and a typical denial is it's based on an invalid modifier or a missing modifier, or it's based on CCI edits. We're going to be going over a whole bunch of these today, give you some good examples on how to deal with these things. Let's start with this one. The service is denied because it was incidental to the major service rendered. One of the most common denial situations in the chiropractic setting is chiropractic does a chiropractic adjustment on the same day as a re-exam. Some health plans, they'll just automatically deny it and say, oh, the re-exam? Nah, we're not gonna pay for that. That's part of the chiropractic pre and post manipulation assessment. If that's the case, then yeah, they're right, but it is not the case most of the time. The reason why you did a re-exam was because something was different that day. At least it should be the reason why you performed a re-exam on the same day as an adjustment. What's a good reason to bill a re-exam, for example, 99213, on the same day as an adjustment? Well, the patient came in and had a brand new problem. Let's say you were treating this patient for neck and lower back, and the patient says, Dr. Kotlar, I have a new problem. My shoulder's killing me. I was playing tennis over the weekend. I got a new problem. Well, that's a good reason to do a re-exam, 99213. So if there's a new problem, an exacerbation, a flare-up, the patient is not getting better as fast as they should. There's many different reasons why to do a re-exam, but it must be a significant, separately identifiable reason. Those are the words you should actually be putting in your documentation. When you do a re-exam, one of the first couple of sentences, it should state, the patient has presented today for a reevaluation. This is a significant, separately identifiable condition. Now, that's very clear in the notes. Another common denial, not medically necessary. Why? Well, it's because we don't pay for manual therapy and an adjustment on the same day. Wait a second. Why not? A chiropractic adjustment and manual therapy, that's right on your screen right there, 97140, that's manual therapy. That can be done on the same day, on the same patient, not in the same anatomic site. Well, so let's say you do that. Let's say you adjust the patient's neck and you do the manual therapy on the lumbar region and you submit the claim with the 5-9 modifier and it comes back denied. Not medically necessary. Why? CCI edit, bundling. Then that requires an appeal, a formal appeal letter. Dear insurance company, I disagree with your decision. This is a formal appeal stating that we did it correctly according to the CCI edits. Chiropractic adjustment on the same day as manual therapy is allowed as long as it's in separate anatomic sites. Take a look at my notes. You'll see I adjusted the neck. Manual therapy was on the lumbar region. That's why we use the 5-9 modifier. This complies with all federal guidelines when both services are being performed on the same day. That's the power of a strong fight back letter, and it works 80% of the time. Yeah, here's an example right here. Same day as an adjustment. Number 2, the service is denied because missing modifier, invalid modifier. These are the first one, 59, very common. That's separate and distinct region. XS, some insurance companies require that. Now don't change it. If you're using the 5-9 modifier properly, then don't make any changes, assuming your claims are getting paid properly, but for some reason, out of the clear blue sky, that's That's what I like to say all the time, out of the clear blue sky, because that's what I hear from CAs at our help desk all the time. Dr. Kotlar, we were getting paid no problem from Aetna. Out of the clear blue sky, they stopped paying for this. Dr. Kotlar, everything was going well. Anthem, Blue Cross Blue Shield, out of the clear blue sky, stopped paying for all our therapy codes. Well, that was because they now want the GP modifier. Maybe you didn't get the newsletter. Literally, they sent out reports, newsletters. It's on their website, Anthem, Blue Cross Blue Shield, which covers, I don't know, about 35 to 40 states in the country. They said, well, as of April 1st, 2021, we want the GP modifier on all the therapy codes, including the G0283 for unattended STIM. So all your 97 codes. 97 is you see it on your screen, 97, that's a rehabilitation code. 25 is on your E&M codes. Have good fight back letters. The AMA, they own the copyrights to the CPT codes and the modifiers. So here's modifier 25, separate and distinct. There's the language I recommend you put in your re-exams. A significant, separately identifiable E&M service was provided today. This patient's condition required a significant, separately identifiable E&M service above and beyond the other service provided. What's the other service? The adjustment. GP is causing so many problems. I don't know if you've been hearing about this, Christy, or anybody else listening to this, but this has been a major issue. It's become alarming and widespread, this modifier GP issue. So Medicare requires it, United Healthcare requires it, and now Anthem, Blue Cross Blue Shield. It's a Medicare modifier, but United Healthcare and Anthem and maybe others have adopted it. It's a service delivered by a physical therapist. Well, wait a second, we're chiropractors, we're not physical therapists. So if you don't use it, it may not get to the secondary, might have issues. So be aware of GP 59. We mentioned that separate, distinct region. The NCCI edits, you may see this in your denials. I know State Farm, Geico, Allstate, they're always referring to the CCI edits. Aetna does it a lot. It's a federal program, maintains a system of edits. So the CCI edits say if you're going to do manual therapy, massage, or neuromuscular, it has to be in a separate anatomic site. Okay, if that's the case, use the 5-9 modifier. 5-9 modifier is used incorrectly by a lot of doctors. Some doctors are using the 5-9 modifier on adjustment codes, x-ray codes, traction codes, and then it causes their modifier use data to cause an insurance company to audit your claims. And they look at your claims and they go, why are you using the 5-9 so much? I had one doctor from New Jersey. The insurance company basically said, you're using the 5-9 modifier on codes that are not necessary. You should stop. If you don't stop, we're going to continue to audit you because your data is alarming. It's coming up like you're using it 95% of the time. All the other doctors are using it 46% of the time. So you want to use modifier 59 properly. It's one of those rare modifiers that bypass the CCI edits. So it's a good modifier to use. Here's the XS, separate structure. All right, we're up to number 3. The service is denied because the time component is missing in the records. Oh, okay. Just had to deal with one of those recently. Doctor is being audited. He is being requested to send in his notes on just a few patients. I think 4 or 5 patients. Not a big deal, just a little spot check. He was billing for 97110. It doesn't have the amount of time spent. You need to write that down. So 1 unit is 8 to 22 minutes, 2 units, 23 to 37. Sometimes it gets a little confusing. You can do manual therapy 97140 for 23 minutes. Can you bill 2 units? Sure. And then let's say you follow that with another 23 minutes of therapeutic exercises. Can you bill for 2 of each? No. You can only bill 3 units. Why? You have to use total time. 23 plus 23 is 46. 46 is 3 units. Next, number 4, payment will be considered upon review of the chart notes. See, this could be a problem. If you submit your claims and they go, we are not paying, denied, why, what's going on? We need to see the notes. You could be in for what is known as a pre-payment audit. Post-payment audits are very common. You've probably heard of those. What's that? Patient comes in, you deliver a service, you bill the health plan pays you. The health plan then says, we want to see your notes. You send in your notes, the health plan says, okay, this is a post-payment audit. We paid you, now we're auditing you. Sometimes they want money back, sometimes not. That's a post-payment audit. This is a pre-payment audit. They want to see the notes before they pay. So this doctor sent in his notes, and it came back, based on your notes, we're not going to ask you for any money back. That's the good news. You could look at this the glass half full or half empty. We're not going to ask you for any money back, doc, so that's the good news. The bad news is now, because your notes, it says there was no plan of care, no time components. Some patients' treatment indicates years of the same treatment without improvement. There were no signatures. The assessments appear to be templated. So they are just listing the reasons why they didn't like this doctor's notes. So again, the good news is they didn't ask for money back. They could have asked for over $140,000 back. They said, no, we're not going to do that. We're going to put you on a prepayment audit. So now he needs to send in his notes with the bills. Number 5, the service is denied because it is included in the contractual obligation and the patient may not be billed. What? Is that true? You may read things. You or your billing manager gets your EOBs electronically, or maybe some of you are still getting paper EOBs, and it says denied. The service is included in the contractual obligation. Is it true or not? This could happen. Just happened recently. Doctor's like, I am out of network with this plan. Why are they considering me in network? And they're processing the claims as if the doctor's in network. It's not okay. Insurance companies, they want doctors to be in network or par providers. This is something I've seen them send to patients. Charge is $150. If you go to a participating Blue Cross Blue Shield provider, you only have to pay $20. If you go to a non-par provider, you may have to pay up to $114. You see how insurance companies want patients to be going to participating providers, and they have a lot of good reasons, and it's working because there are tens of thousands of chiropractors that are participating providers with Blue Cross Blue Shield, Aetna, Cigna, Ash, Optum, United Healthcare. Yeah, and there are pros and cons to being in network, pros and cons to being out of network. I'm not going to tell you to join. I'm not going to tell you to drop out of any plans. Pros and cons to being in, pros and cons to being out. Number 6, the benefits are denied because the diagnosis is inconsistent with the procedure. See, there are some insurance companies, they want you to pair your procedure codes with your diagnosis codes, almost like pairing food and wine. You want to pair white wine with fish traditionally, red wine with meat. So CPT codes, maybe that's the meat, and the ICD-10 codes, that's the red wine. You should be pairing them. Yeah, here's a little example. Traction pairs with radiculopathy and disc degeneration. I consider myself a coating sommelier, not a wine master. Oh, yeah, so a lot of these pairings I have in a book that I wrote. This is my book on the best chiropractic codes to improve reimbursement. So it tells you how to pair your codes and the codes that pay for the most visits. Number 7, the benefits are denied because the diagnosis is not substantiated in the patient records. Yes, I've seen this one. This comes down to documenting, making sure your documentation is substantiated based on the diagnosis code. So, for example, you're going to diagnose a patient with cervical radiculopathy. That's M54.12. It's an advanced diagnosis. It's may require long-term treatment. The patient, your notes should say, patient stated that he or she has pain in the neck radiating into the arm, or numbness or weakness or tingling. That should be something the patient verbally says. Check that box. Next, we're building a cervical radiculopathy diagnosis right now. First box that needs to be checked, the patient has to say, my neck hurts, pain down the arm. Box number 2, your exam should include some Jackson compression. Now, this is where I mentioned earlier, I'm going to combine my 16 years of being in the trenches, treating patients as a chiropractor, and now I'm a certified coder. I'm an expert in billing and coding and compliance, so I'm combining the two, giving you some clinical information here to help justify your billing. So Jackson compression, maybe some Sperling shoulder depression, a couple of ortho tests, some neuro tests, maybe check for myotomal weakness, your typical chiro test, limited motion, palpatory tenderness, subluxation. Then go ahead and report cervical radiculopathy. Do you need an MRI? In my opinion, no. Again, that's my opinion. For a herniated disc, bulge disc, you suspect some sort of disc prolapse, protrusion, bulge, herniation. Oh, then yeah, for sure, I recommend imaging. So M5412, again, you want to be able to justify. So this is how I'm combining, my chiropractic experience with billing experience. You're going to diagnose a patient with sciatica. You should do straight leg raise. I was just reviewing a doctor's charts about 2 months ago. He submitted a claim to a managed care organization to get more visits. He diagnosed the patient with sciatica. He asked for 8 visits. They approved 2. One of the reasons why they said we're only going to give you 2 is because there were no abnormal ortho-neuro-chiro tests. This doctor didn't even do straight leg raise. Sciatica? Come on, you need to do straight leg raise. If you don't, then I don't know why, but again, that's clinical stuff. Number 8, the charges were applied to deductible, and therefore payment cannot be made. Well, is that true? It's not always the case. Deductibles, co-pays, co-insurance. This is another important part of running a successful chiropractic practice. Let me ask everyone a question. Is it okay to waive deductibles, co-pays, and co-insurance? The answer is maybe. It depends. Case-by-case basis. I'll give you one example where it's okay to waive a copay. Here comes Mr. Thompson. He has a $30 copay. He forgot his wallet. Next visit, again, he forgets his wallet. Next visit, Mr. Thompson, now you owe $90. Oh, again, forgets his wallet. Now he owes $90. You make an appointment. He doesn't show up for his next appointment. You send him a statement, doesn't respond. You call, doesn't respond, disappears. In that case, you could waive the $90 copay. So there are certain instances where it's okay. It's the routine waiver that's not okay. Now, those of you that are brand new to the insurance world, the deductible right there on your screen, it's the amount the patient has to pay prior to the insurance company paying. Co-insurance is usually for out-of-network providers. Co-pay is usually for in-network providers. It's a flat fee. So it's the routine waiver of co-pays and deductibles that is the issue. For example, I know one doctor, he has patients coming in from Wells Fargo. This doctor's practice is next to an office building where all these employees are coming in. There must be 200 employees of this company next to him, and they all have fantastic insurance. It covers like 90%, no deductible. So he's not collecting anything, and now he gets a letter. Dear doctor, we have found out that you are not collecting co-pays and deductibles. Please provide us with proof that you're collecting co-pays. You see, that's not okay. No routine waiver. It's not okay to say all employees of all the teachers, we're going to waive the copay. No, not okay. All the employees of Bank of America, we're going to waive the copay. We're going to waive the deduct. No. Nope. Number 9, the service is denied because it excludes 1 and excludes 2 bundling. Yeah, we mentioned CPT code bundling. For example, re-exam and an adjustment, manual therapy and an adjustment. So that's CPT code bundling. Excludes 1, excludes 2 is an example of diagnosis code bundling. So yeah, you've probably heard of it, CPT bundling, I mean. If both of these procedures are performed in the same anatomic site, the CCI edits kick in and bundle the codes. Well, there's ICD-10 code bundling. Example, you diagnose the patient with low back pain and M54.41, which is low back pain with sciatica. That will cause a problem. Muscle disorder codes, codes that begin with M62, on the same claim with myalgia type codes that begin with M79, that will cause a denial. So be prepared. Again, you might say, we've been getting paid, no problem, Dr. Kotlar. Cigna has been paying us, no problem. Out of the clear blue sky, they denied us based on this excludes 1. They're saying that our diagnosis codes are not bundled. There you go. There's another one. Number 10, claim rejected due to discontinued G codes. Hopefully you're not dealing with this anymore. Beginning of the year, a lot of doctors were contacting us. We can't bill the Medicare G codes anymore. Well, you probably don't need to because of the Medicare incentive payment system. It uses measurement codes for incentive payments or reductions. So if you qualify, then contact your EHR company. But in order to qualify, you have to be billing more than $90,000 and seeing more than 200 Medicare Part B patients. So that's probably ruling most of you out. Most chiropractors don't collect that much. So you don't need to report these codes because you are not invited to the party. You don't have to because you don't qualify. You didn't meet the threshold. But if you did meet the threshold, then you are automatically included in the MIPS program, which, if you're not familiar with that term MIPS, which stands for the Medicare Incentive Payment System, it kind of took over. Remember the PQRS and the meaningful use? You remember those terms? Yeah, those segued into the MIPS program. Number 11, treatment plan is missing or incomplete. Yeah, need to have a good treatment plan. This is what you should have. This is what we recommend to all of our clients. First visit, history, exam, diagnosis, goals, list the services, the clinical rationale, so you're pairing your CPT codes and diagnosis codes, and the schedule of care. What's that? 3 times a week for 4 weeks and then reevaluate. So treatment plan, very important. It's the foundation for care. This is not a soap note. A treatment plan is not a soap note. A treatment plan is what? History, exam, diagnosis, goals, services rendered, schedule of care. It's a lot of stuff. A typical soap note is SOAP. Patient has pain, they give them an adjustment. It's very different. So hopefully you are creating good treatment plans. And whatever is abnormal on the first visit, those are the things you should be retesting on every re-exam. For example, the patient comes in, straight leg raise is abnormal. Well, on re-exam, redo that one. On the first visit, if you check a patient's blood pressure and it's normal, on re-exam, do you need to recheck it? If nothing has changed in their history, I don't think you need to repeat the blood pressure again unless you want to. The patient's reflexes are abnormal on the first visit, oh, recheck that. The patient states that she cannot lift more than 5 pounds on the first visit, well, recheck how many pounds she could now lift after a month of care. Number 12, the charges are denied. The patient is responsible for the balance. Really? Maybe, maybe not. Have good financial forms, have good financial policies. You have to have a good quality financial policy. Why? Because the doctor deserves to get paid for everything he or she does, right? And you want to prevent upsets. Any patient that's having problems paying, any patients that don't have insurance, there's many different patients that qualify for a discount medical plan organization. Guess which one I like the best? There's many out there. ChiroHealthUSA. A lot of people have asked me, why do you like ChiroHealthUSA? There's many reasons. First of all, they give back to the profession more than any other DMPO. Actually, they probably give back to the chiropractic profession more than most all chiropractic vendors. So to me, that's important. I like to align myself with companies that give back to the profession. So just that alone, it's a great reason to use them. Plus, they have vetted this better than anyone. The owner of the company has spent hundreds of thousands of dollars making sure that this is legal and proper. So, discount medical plan organization, ChiroHealthUSA, doesn't cost you anything to join. Any patient comes in, no insurance, you want to give them a discount? There you go. Now, one of the most important things, if you are treating patients for wellness, is to understand the difference. So what's medical necessity? Well, it depends who you ask. If you ask Medicare, here's the definition. It's a service, treatment that is required to identify an illness or an injury. It's consistent with the symptoms and diagnosis. It's appropriate under the standards of care. It's not solely for the convenience of the patient or the doctor. It's the most appropriate service which can be safely provided and accomplishes the desired end result. So that's the formal thing. Remember, you're going to get these denials. Denied. Why? It's not medically necessary. Well, here's the definition of medical necessity. And it's funny, it says not solely for the convenience of the participant, which is the patient or the doctor. What does that mean? I recently I'm working with a doctor that was treating this patient for many, many visits, over 120 visits. Yes. Now the health plan wants to see the notes. Many of the notes say the patient wanted this, the patient wanted that, the patient likes coming in, the patient wants more care. It was as if the provider was just whatever the patient wanted, the provider would provide and bill the insurance. It's not the way it's supposed to be. It's up to you, the doctor, to decide what the patient needs. And secondly, who's going to pay for it? So there are many definitions of medical necessity. Aetna has their definition, Blue Cross Blue Shield. What's my definition of medically necessity? Patient has pain, discomfort, can't bend, can't lift, can't do their normal activities of daily living. They have restricted motion. That's medically necessary. Insurance will pay for that stuff. 91% of the American population have insurance that covers chiropractic. So when a patient comes in to your office, they probably have insurance that covers chiropractic. Now it's up to you to accept it or not, be in network or not. Pain, restricted motion, that's medical necessity. Now maintenance or wellness care, what's that? It depends who you ask. How about Medicare? Medicare says maintenance includes services that seek to prevent disease, promote, and prolong or enhance quality of life. It's not covered. Wellness care. This is what we teach our clients to say. Mr. Jones, congratulations. Over the past 2-3 visits, you've told us that you don't have any more pain. You have great range of motion. You were able to play tennis. You were able to do all your activities of daily living. Congratulations, you've reached the wellness stage. If you'd like to keep coming in, we have an affordable fee, but there's no more insurance billing at this point. And then the patient makes a decision. At maximum therapeutic benefit, try to transition patients to wellness. In my practice, my conversion ratio was 40%, meaning every 10 patients that came into my office that had insurance, once the insurance ran out or they got to wellness, 4 out of 10 stayed. I'm not so proud of that statistic. 40% stayed. 60% went bye-bye and they didn't come back unless they were hurting again. So there are different types of phases of care. I see many doctors put labels of phases of care. The patient's in the acute phase, subacute, relief, initial intensive, active, medically necessary, therapeutic, corrective, rehabilitative. I don't mind if you put, from a compliance standpoint, I'm okay if you label a phase of care. However, in my opinion, as far as billing and coding, there's only two categories. Category 1 is active care. Category 2 is wellness maintenance care. You see it on your screen. The patient comes into your office. You need to make a decision, either before the visit or after the visit. Is this one of two categories? Active care means the patient has neck pain, back pain, restricted motion, inability to perform normal activities of daily living, spasm, decreased functional performance. That's active care. That's typically covered by insurance because insurance considers it, quote unquote, medically necessary. And if you follow the red arrow down, it shows you. There are the codes. Patient pays cash. If you're out of network, that's great. The patient might say, could I get a statement, an invoice? Great. Give them a statement, give them an invoice. They'll probably get paid some money back because that's medically necessary care. Or if you're in network or if you are seeing a Medicare Part B patient, you have to bill. Now we go over to the other category. There's only two. Remember, every man, woman, and child in your office has to be placed in one of these two categories on the day of the visit. Let's go to the wellness category. The patient has very little pain or no pain, has good motion, can perform all activities of daily living. This is wellness care. Or once the patient has plateaued and they've reached maximum therapeutic benefit, that's considered maintenance care. Wellness and maintenance, not covered by health insurance because they consider it, quote unquote, not medically necessary. What's the billing for wellness care? S8990. Now the patient might say, all right, could I get a statement, an invoice, a super bill? Sure, give it to them. S8990, it's going to get denied. Insurance doesn't pay for that. Some are starting to pay for it, but 99% don't. The only exception is Medicare. They don't recognize S8990, so you need to continue to use your regular CPT codes and diagnosis codes. You just need to use the GA modifier if the patient checked yes to option 1 on the ABN form. Okay, so Christy, I'm just going to wrap it up with a couple of self-test questions. Here we go. Do you conduct regular formal meetings on coding and compliance with your billing and staff and log them in a compliance manual? Do you have meetings with all doctors and providers on documentation and log those in a compliance manual? Do you do background checks on all employees and billing companies? You train your staff on different supervision levels. You train your staff on the proper way to collect co-pays, deductibles. These are the things that you should be taking care of, doing internal trainings. It's part of compliance. That's what we specialize in, compliance. A lot of people say, Dr. Kotlar, you're the insurance guru. No, if you want to put a label on me, I'm the compliance guru. And that's what we do at Target Coding. We specialize in compliance as it relates to billing, coding, Medicare, and HIPAA. All right, Christy, if any questions came in, I'm ready for those.
We do have a question. It says, I've had claims denied this month for the 59. What is the best way to resubmit them?
The best way to resubmit them is to find out what the insurance company wants, right? That's the big question. So what you should not do is guess and gamble. You should not just resubmit with this or resubmit with that. Oh, I'll try this. I think that's dangerous. And definitely don't do that with Medicare because they frown upon just resubmitting claims just for the heck of resubmitting. So the best advice is to that person, if you got denied because of a 5-9 modifier issue, contact the health plan and demand to speak to someone that can give you the answer. Now, if you can't get an answer, then go ahead and guess. If it's not 5-9, if I had to take a guess, you want me to look into my crystal ball, I would tell this doctor, try the XS. If that doesn't work, okay, I'll look into my crystal ball. Try the 97. If that doesn't work, we can go on and on and on, but that's dangerous.
Okay, the next question is, do you have an example of a fight back letter? I tried to download the one from the presentation but can't read it.
Oh, yeah. If anybody would like a copy of our fight back letter for the manual therapy, yeah, we can send that. Yeah, right there. I have my contact. Send an email to info@targetcoding.com and we'll send you that fight back letter.
Okay. I'd love to get additional information on Blue Cross Blue Shield denying re-exams. Where would I find that?
Well, if you give me the reason why, I can show you where to find it. What is the reason why they're denying? Again, it goes back to that very first slide. Denied. Why? There's about 25 to 30 reasons. So this question is, our re-exam got denied. I would like to know why. I can tell you why if it's a Medicare Part B patient. Medicare doesn't pay chiropractors for re-exams. So maybe it could be as simple as that. Medicare Part B doesn't pay for re-exams.
She said that they state pre-op, post-op period.
Great. So I disagree with that. So you should send them a letter. It should say something like this. Dear Blue Cross, is it Blue Cross Blue Shield, or dear auditor, I don't know, to whom it may concern, we disagree with your decision. The re-exam was done properly according to the American Medical Association. Under the chiropractic CPT code section, it states that chiropractors are allowed to get reimbursed if the patient has a significantly separately identifiable condition above and beyond the usual pre and post-service work. Please see my notes. You will see that this patient came in with, and I mentioned all the different examples, a new problem, an exacerbation, a flare. You send that to them. Now they pay you, great, but wait, what happens if they go, we're still not paying? Then the doctor should contact me right there, set up a free consultation, and I'll tell you the next steps.
Excellent. Several people were asking about access to the webinar recording. Everyone who registered will get a link to the recording later this afternoon. It's also going to be available starting tomorrow under archived webinars. All you have to do is search for Dr. Marty Kotlar to get access to that. I don't see any more questions. I see a lot of great feedback, and thank you, Dr. Kotlar, for your excellent explanations on a lot of people had a lot of questions about denials in their office, and you definitely helped them to understand what was going on.
Excellent. Thank you for having me.
It is always a pleasure. So I want to thank everyone for joining us today. Just a reminder, our next webinar will take place in a month. It was Dr. Scott Gray, and it'll be Marketing Success in the New Normal will be our next webinar. So we have a whole month. So I hope you'll utilize these Tuesdays when you're used to having weekly webinars with ChiroHealthUSA. Go back and watch some of these recordings. Definitely share them with your team to help them with all of these great nuggets of information. If you are the only one watching these webinars, well, you're not the only one who should be doing all the work in the practice. I can think of so many staff members who would benefit from today's webinar presentation with Dr. Marty Kotlar, as well as so many other webinars that we've presented. Just so y'all know, we're going to be doing 1 to 2 webinars a month instead of one every week for the remainder of the year. And we do have a new podcast that we will be announcing soon, where we'll have a lot of the same guest speakers talking about the hottest topics in chiropractic. And we're so excited to share that with you. So that information is coming soon. Dr. Kotlar, thank you so much, as always, for making yourself available to all of our CHUSA providers in the chiropractic profession. And I am counting the days till I see you in Florida.
Oh, absolutely. Looking forward to seeing you. Take care. Thank you, Christy.
You're welcome. Everybody have an amazing rest of your day. and a fabulous week. If you're like me and you think of a question for Dr. Kotlar after today, you can reach out to me, Christy at ChiroHealthUSA.com, and I'll be happy to connect you with Dr. Kotlar and his amazing team. They are like one in a million, and to get you connected so that they can get your questions answered. You can also email info@targetcoding.com, and I encourage you again to visit targetcoding.com to see all of the great information that Dr. Kotlar provides his audience, upcoming webinars and seminars that he is hosting. And like I said, hopefully, fingers crossed, I know this girl is hoping soon in 2022 or 2023 that we're going to get back to the wide open seas for a coding and documentation seminar. This was my year that I was going to get to go.
Well, we have one right now temporarily booked, so we'll see. I don't want to release the date yet, but we do have another cruise seminar in the works.
I mean, can y'all think of anything better than, working on your practice from a cruise ship? Because I can't think of anything better.
Yes, if you like cruising, then it's one of the best ways to have a vacation and get CE credits.
It is awesome. Well, I cannot wait to hear the info from Natasha once she'll finalize everything. So everybody, go be great. Go have an impact. Change the world. Change your communities. And I will see y'all in a month. Bye, y'all.